So hamstring muscles, they are the group of the muscles of the back of the thigh. The word hamstring means, ham means back of the thigh. And string means the tendons of these muscles. So that's why we call the hamstring. So they are tendons, they are present behind the knee joint, and when we touch them, they looks like or feel like the strings. That's why they call the hamstring muscles. Now there are 4 hamstring muscles. Names of these muscles, they are semitendinosus, semimembranosus, long head of biceps, femoris, and the ischial head of adductor magnus. So these 4 muscles, they are labeled as the what is called the hamstring muscles. And another thing about the hamstring muscle, that these 4 hamstring muscles, they follow the hamstring rules. So there are 4 hamstring muscles and there are 4 rules of the hamstring. One is the rule of origin, then rule of insertion, then rule of nerve supply, and 4th is the rule of the action. So all 4 muscles, hamstring muscles, they follow the 4 hamstring rules. That origin, insertion, nerve supply as well as the action of all these 4 muscles is the same. So they are called the hamstring rules. That's why they have been grouped together. So we'll take one by one what are these muscles and how they follow the rules. So first is the rule of the origin. So all these muscles, they take origin from the ischial tuberosity. And the rule of insertion is they are inserted on either bones of the leg, either tibia or fibula. Then nerve supply. All these 4 muscles, they are supplied by the tibial component of sciatic nerve. Tibial component of the sciatic nerve, that is the L4, 5, S1 and 2. Then action. All these 4 muscles, they have got the same action, that they act on 2 muscles because 2 joints, they cross the 2 joints. One is the hip joint, another is the knee joint. So when they act or when they contract, they bring about the extension at the hip joint, and they are flexors at the knee joint. So their action is the same. So they bring about the these muscles. So they are the hamstring roots. So we will take one by one. So first of all, whenever we have to do any dissection part, we should know what are the bones in that region. So when we see the backside of the thigh, that is the gluteal region first of all. Then bones in this region, as we have done. That is the sacroiliac joint, this is the sacrum. Posterior superior spine, posterior inferior spine is the iliac crest, the outer lip, inner lip. This is the greater sciatic foramen, the ischial spine, this is the lesser sciatic foramen, and this is the ischial tuberosity. This is the hip joint, that is formed by the head of the femur. This is the neck. This is the lesser trochanter. This is the medial border of the femur. This is the adductor tubercle, and this is the medial condyle of the femur. Here this is the greater trochanter, lateral border of the femur. This is the lateral condyle of the femur, and this is the intercondylar rough area. Behind here lies the linea aspera, or the posterior border of the femur, and below it is continued as the medial supracondylar line and the lateral supracondylar line, and in between there lies the smooth popliteal surface of the femur, where there is no any muscle is attached. Popliteal surface, triangular surface just above the medial condyle and the lateral condyle. When the knee joint formation, same reciprocally medial condyle of the tibia and the lateral condyle of the tibia articulates with each other. This is the shaft of the tibia. And this is the laterally the fibula bone articulates the tibia to form the superior tibiofibular joint. And on the posterior surface of the shaft of the tibia, there lies a spiral line, that is the soleal line. And there is an interosseous membrane between the tibia and the fibula. So this is the backside of the knee joint. So hamstring muscles, they lie behind the back of the thigh. So in the dissection, we cut the skin of the back of the thigh and we reflect the skin laterally to visualize what is the hamstring muscles. So first muscle we will see the semitendinosus. So as the name semitendinosus is called semitendinosus because its origin as well as the insertion is tendon-like. It is a cylindrical muscle. Before going into the origin of the muscle, we have to study what is the ischial tuberosity. Now the ischial tuberosity is the most dependent part and most thickest part of the hip bone because it is weight bearing. So during sitting position, whole of the weight of the body falls on the ischial tuberosity. And ischial tuberosity is divided into upper part and the lower part by a horizontal line. Into upper and lower part. The upper part is further divided by a obliquely running line, and two areas are present. One is called the medial, is called the inferomedial. Inferomedial area, and other is the superolateral. So this oblique line divides the upper part of the ischial tuberosity into the inferomedial and superolateral area, while the lower part of the ischial tuberosity is divided again by a oblique line into a medial and a lateral area. The medial area is smooth because this is touching the surface in sitting position, while the lateral area is rough. So that is how we describe what is the ischial tuberosity. So the muscle semimembranosus is called semimembranosus because it is membrane-like. It is a ribbon-like muscle. Whatever width is at the origin, same width will be at the insertion. That's why we call this semimembranosus. So this semimembranosus muscle takes origin from the superolateral area of the ischial tuberosity. So this area is for the semimembranosus, and this muscle runs downward vertically and it is inserted over the posterior surface of medial condyle of the tibia. Posterior surface of the medial condyle of the tibia is the insertion of what is called semimembranosus muscle. There is a membrane-like, a ribbon-like. At the insertion, a aponeurotic extension of this muscle runs upward and laterally and obliquely and it forms the oblique popliteal ligament. Oblique popliteal ligament which is fused with the posterior surface of the fibrous capsule. Its few fibers, they arc downward and laterally towards the lateral condyle of the tibia, and it forms the arcuate popliteal ligament. Arcuate popliteal ligament, below which the tendon of the popliteus muscle becomes extracapsular. The popliteus muscle becomes extracapsular. Then the next muscle we will do is the semitendinosus. Semitendinosus is tendon-like at the origin as well as the insertion, and this muscle takes origin from the inferomedial part. Origin of the semitendinosus and the long head of the bicep is the common. Both take combined origin. The semitendinosus medially, while the long head of the bicep from the lower part of the inferior medial area. The semitendinosus muscle runs downward vertically over the semimembranosus muscle or on the posterior surface of the semimembranosus muscle, and this tendons behind the knee joint runs lateral to the medial condyle of the tibia, and then the semitendinosus muscle is inserted over the upper part of the medial part of the shaft of the tibia. The insertion of the semitendinous is aponeurotic, and its insertion is just medial to the insertion of the gracilis muscle and sartorius. So upper medial part is the insertion. So inverted hockey shaped insertion is of the sartorius. Then comes the medial to the sartorius, the gracilis muscle is inserted, and then medial to the gracilis, semitendinosus muscle is inserted. So all these three muscles, they are inserted on the upper medial part of the shaft of the tibia. So they are inserted in a very small area. It is only possible because the tendons, they are aponeurotic, means they are thin and paper-like, sheet-like. Then how to remember? There is a formula to remember. That is the girdle between two sardars. One sardar is lateral, that is the sartorius. One S sardar is medial, that is the semitendinosus, and G for girdle is lying in between. So this is how to remember the formula. Girdle between two sardars, that is the three muscles inserted over a small area. And if you trace these three muscles, they are also called the gyropes. Gyropes of the hip, because this sartorius, for example, it takes origin from the anterior superior iliac spine, that is from the ilium. The gracilis muscle, it takes origin from the body of the pubis, just near the pubic symphysis. And semitendinosus muscle takes origin from the ischial tuberosity. So there are three parts of the hip bone: ilium, pubis and ischium. From all the three parts, these three muscles, they take origin. And all muscles, they are coming down and they are inserted on the same area. That is where the upper medial part of the hip. So during standing position, they are called gyropes, because these three muscles, because of their insertion into the tibia, they steady the pelvis on the femur, or in other words, on the lower limb. So they are the stabilizer of the standing posture also. That's why they are called the gyropes of the hip bone. Then comes the long head of the bicep. Femoris. Remember, not the short head. Only hamstring rules are followed by the long head of the bicep. So we only include the long head of the bicep, not the short head. Now this long head of the bicep muscle, as we have already told, that it takes share the origin from with the semitendinosus from the inferior-medial area. So from this inferior-medial area, the long head of the bicep passes below the semimembranosus muscle, and this long head of the bicep runs obliquely, laterally on the posterior aspect of the shaft of the femur, and in the middle part of the femur, from the linea aspera, the short head of the bicep muscle meet with long head, and they forms a tendon, and this tendon runs laterally behind the lateral condyle of the femur, behind the fibrous capsule of the knee joint, behind the lateral condyle of the tibia, and the tendon of the bicep muscle skirts around the fibular collateral ligament, which is attached to the apex or the styloid process of the fibula head, and the tendon of the bicep is inserted around the fibular collateral ligament in a U-shaped manner, encircling it medially, laterally and posteriorly. So that is how intimately the tendon of the bicep is related to the fibular collateral ligament. So it is inserted over the head of the fibula, so it follows the rule of the insertion that either bone of the leg. Then comes the last muscle of the hamstring group, that is called the ischial head of adductor magnus. As we know, adductor magnus is taking origin from the pubic bone, ischium bone also, and the lowermost fibers of the adductor magnus takes origin from the lateral part of the body of the pubis, then from the ischiopubic ramus, and this reaches up to the ischial tuberosity. So the last fibers from the ischial tuberosity, from the medial part of the ischial tuberosity, they are the last part of the adductor magnus. So from this point of origin, the muscle is called the hamstring part or ischial head, because the upper part is taking origin from the pubic bone. Only the last fibers of the adductor magnus, which takes origin from the small area of the medial part of the ischial tuberosity, they are included in the hamstring. So the muscles from the medial part of the ischial tuberosity, the other fibers of the adductor magnus, goes there, while the ischial fibers, they come inserted over the adductor tubercle. They are tendinous. So these fibers which are inserted over the adductor tubercle of the adductor magnus, they doesn't stop here. Beyond the adductor tubercle, a aponeurotic extension of the adductor magnus muscle runs downward and inserted over the medial surface of the medial condyle of the tibia. So from the adductor tubercle to the medial condyle of the tibia, this is the aponeurotic extension of the adductor magnus muscle, and this part is called the hamstring part of the adductor magnus, and this is called the medial, it forms the medial collateral ligament of the knee joint. Medial collateral ligament of the knee joint. So from adductor tubercle to the medial condyle, so this is the part of it. The medial collateral ligament is the ligament of the knee joint. So this is how we include the ischial head of the adductor magnus, because it also, this is the only part of the adductor magnus which follows the hamstring rule, that it takes origin from the ischial tuberosity, medial part from the ischial tuberosity, then inserted. It is also inserted on the tibia as a tibial collateral ligament. So this is how we do the all four muscles, their origin and insertion. Now come their nerve supply. As we know, the sciatic nerve is coming from the greater sciatic foramen, the thickest nerve of the body. It runs obliquely downward in the gluteal region. Then it runs between the greater trochanter laterally and the ischial tuberosity medially, covered by gluteus maximus muscle. At the lower part of the gluteus maximus muscle, this sciatic nerve is exposed as no muscle is covering it. Then this nerve passes downward and crossed by the long head of the bicep femoris muscle. Its medial fibers are the tibial component. Its lateral fibers, they are the common peroneal component. So from the medial part of this sciatic nerve, the branches arise which supply the semimembranosus. They supply the semitendinosus muscle. They supply the long head of the bicep muscle, as well as the ischial head of the adductor magnus. Then this nerve, sciatic nerve, goes into popliteal fossa at the upper apex, where it is bifurcated into the medial tibial nerve, and later is the common peroneal nerve. At the junction of the upper 2/3 and lower 1/3 of the posterior surface of the thigh is the level of bifurcation of the sciatic nerve at the upper apex of the popliteal fossa, or what we say at the junction of the upper 2/3 and lower 1/3 of the back of the thigh, into lateral common peroneal nerve, which follows the tendon of the bicep muscle, and the tibial nerve, which is vertically downward and continuation of the sciatic nerve. So the medial fibers of which are the tibial component, they supply the hamstring muscles. So they follow the nerve supply of this. So this is how we do the hamstring muscles. Now come their applied anatomy. In the applied anatomy of the hamstring muscle, if the sciatic nerve is damaged or cut, it leads to the paralysis of the hamstring muscles. And paralysis of the hamstring muscle lead to the loss of extension at the hip joint. Loss of the extension, and the walking becomes difficult. Then comes the hamstring sprain. This is the sports injury, usually in the athletes who are playing the football, rugby or hockey. Here, because of the sudden spasmodic contraction of the hamstring muscles, they are uprooted from the ischial tuberosity. That lead to the weakness of the action of these muscles, which is a painful procedure, is called the hamstring sprain. Another applied anatomy is related to the tendon of the bicep femoris. As we know, the bicep is inserted over the head of the fibula, and and it is accompanied medially by the common peroneal nerve, which runs downward along with the tendon of the bicep. Then this, after the muscle is inserted over the head of the fibula, the common peroneal nerves further descend downward and it runs obliquely lateral to the fibula and reaches the neck of the fibula, where it is divided into superficial peroneal and the common peroneal nerve. And this is the point where the fracture of the fibula is very, very common, and the common peroneal damage lead to the foot drop deformity. So, in the condition of what is called the spastic paraplegia, in the spastic paraplegia patients, the nursing care becomes difficult because of the spasm of the hamstring muscles, and the nursing care of the shifting of the patient in hourly intervals, right and left, and supine and position. The spasmodic paraplegia lead to the spasm of the hamstring muscles, and when we put our fingers behind the knee joint, here we can easily feel the laterally string-like tendon of the bicep femoris, and medially we feel the semitendinosus tendon and the thick fleshy semimembranous tendon behind. So they feel like the strings. That's why they call the hamstring. So nursing care becomes difficult when the knee is in the semi-flexion position. So in this case of this spastic paraplegia, we cut the hamstring tendons to make the lower limb in the extended position, knee joint in the extended stage, which facilitate the nursing care more easily. So a surgeon, while cutting the tendons of the hamstring behind the knee joint, he or she should know the relationship of the bicep tendon with the common peroneal nerve. Because if we see the tendon of the bicep and the common peroneal, their thickness is almost the same. So by mistake, the surgeon cut the common peroneal nerve with the tendon of the bicep, and that lead to the post-operative foot drop deformity. Then the difficulty of this spastic paraplegia patient becomes more aggressive, more grave. So this should be kept in mind while operating upon the strings of the hamstring muscles behind the knee joint. So this is what we do. Another thing which we have left in the front of the thigh, there is a condition which is called meralgia paresthetica. Meralgia paresthetica. This is a condition which involves, due to the lateral cutaneous nerve of the thigh. Usually lateral cutaneous nerve of the thigh passes above the inguinal ligament. But in some conditions it may pass through the fibers of the inguinal ligament, and this lead to the compressive neuropathy. And patient come with the complaint of the pain along the distribution of the lateral cutaneous nerve of the thigh. So lateral part of the skin of the thigh becomes painful. So this is called the meralgia paresthetica. So the treatment is the surgical procedure. Here we cut the few fibers which are overlapping the lateral cutaneous nerve of the thigh, and patient got relieved from this pain. Another applied related to the gluteal region is the injury of the hip joint, hip bone in the roadside accident or anywhere, which lead to the injury of the superior gluteal nerve. The superior gluteal nerve, as we know, it supplies two muscles, gluteus medius and minimus. So both these two muscles, they get paralyzed, and paralysis of this muscle lead to these two muscles lead to the waddling gait. Waddling gait. Or duck-like gait. So in this gait, what happens? The muscles which are paralyzed side, the hip bone is tilted on that side. On the normal side, the muscles are normal and they act normally, but on the paralyzed side, muscles becomes relaxed and they becomes longer, and the hip joint is comparatively weak to the weaker, and the anterior superior spine of the affected side of the side is higher and of the normal side is lower, and this lead to the tilting of the pelvis. So while the person is walking, he will put the hand on the affected side, on the iliac crest and the anterior superior spine, and pushes it downward to equalize the two anterior superior spine, or he want to steady the pelvis which is tilted and raised on the affected side. So while he is walking, he put his whole pressure of the left hand, or for example if the left is paralyzed, superior gluteal nerve is involved, he will push the right and he will walk like this. So his whole of the body sways like this. So such a gait is called the waddling gait. And to confirm the diagnosis of the injury of the superior gluteal nerve, a test is done that is called the Trendelenburg test. Trendelenburg test. In the Trendelenburg test, we ask the patient to lie down in this supine position, and while the position of the supine position is there, then we see the level of the anterior superior spine. On the affected side, it is higher and it is lower in the position. So this is how the Trendelenburg test is done to confirm the diagnosis of the superior gluteal nerve. So that's all about the hamstring muscle. Now we will discuss, after doing the hamstring, now we will discuss the popliteal fossa. So popliteal fossa is the depression or hollow behind the knee joint. So it is a diamond shape or quadrilateral area behind the knee joint. So as we know, knee joint is formed by the lower end of the femur. This is the posterior view of the knee joint. Lateral condyle and medial condyles, with the intercondylar rough area, and the upper end of the tibia. the soleal line, and laterally there is the articulation of the fibula with a large head, narrow neck, and the shaft, and here lies the interosseous membrane, and the fibrous capsule covers the condyles of the tibia and femur, and this is the attachment of the fibrous capsule. And just below the posterior to the lateral condyle of the tibia, there is a gap of the fibrous capsule is interrupted here. And laterally, from the lateral condyle, the fibular collateral ligament is attached to the starter process. And medially from the medial condyle, tibial collateral ligament is attached to the medial surface of the medial condyle of the tibia. So after the attachment of the fibrous capsule, we can't see the condyles, so they are all intracapsular. And posteriorly, this is the insertion of the, on the medial condyle, insertion of the semimembranous muscle, from where aponeurotic extension is fused with the posterior surface of the knee joint fibrous capsule. This is called the oblique popliteal ligament, and a few fibers, they arc like the gap of the fibrous capsule over the exit point of the popliteus muscle. So the extension of semimembranous muscle. In the upper part, there is a lateral supracondylar line and the medial supracondylar line, which are continuation from the linea aspera, and this is a triangular popliteal surface of the femur. And this is the adductor tubercle. Just above the adductor tubercle, there is a hiatus magnus, and this is the attachment of the adductor magnus muscle up to the adductor tubercle, and from the insertion, a aponeurotic extension of this adductor magnus goes parallel with the fibrous capsule and as a medial collateral ligament. Or the tibial collateral ligament. So we should be familiar with the bones whenever we are doing the popliteal fossa, with the skin of the popliteal fossa here. So we will discuss the popliteal fossa under the headings of roof, the boundaries, contents, floor, and apply. So one by one we will cover everything about the popliteal fossa. So regarding the roof, it is formed by, number one is the skin, number two the superficial fascia, and number three is the deep fascia. So in the back of the knee joint, the popliteal fossa is there. So in the dissection part, we will cut the skin in the lower part of the posterior surface of the thigh, and the lower incision horizontally is given on the skin of the posterior surface of the leg, and another incision is given in the middle, and the roof is removed, the first part that the skin is reflected. So when we reflect the skin, the second layer of the human body is visible, that is the yellow color fat, which is held by the loose areolar tissue. Everywhere yellow color fat, if we are seeing, means we are seeing the second layer, that is the superficial fascia of the popliteal fossa region. The fat is held by the loosely arranged, widely separated collagen fibers. And in this solar fascia of the popliteal fossa, from the lateral aspect, we see a vein is coming and almost disappearing in the middle of the popliteal fossa. The vein is visible. The superficial vein, this is called the short saphenous vein. Short saphenous vein. And along this vein, on the lateral aspect, we see a nerve is also coming. And this nerve is called sural nerve, almost parallel with the vein. Then we also see around the vein some occasional lymph nodes also. Medially, we can see sometime the saphenous nerve. Saphenous nerve. Then in the middle of the upper part of this posterior part of the thigh, we also see the termination of the posterior cutaneous nerve of thigh. Posterior cutaneous nerve of the thigh. So these are the structures we have to see in the superficial fascia of the roof of the posterior triangle of the popliteal fossa. Now this sural nerve is very important because this is used for the nerve grafting. Whenever it is required, nerve grafting, we use the sural nerve. And in the middle of the here, we see a nerve that is the, this is the sural nerve actually. Sural nerve is not laterally placed, it is present in the middle lower part of the popliteal fossa, is the sural nerve. And sometimes a sural communicating nerve may be seen. Sural communicating nerve. Is a branch of the common peroneal nerve. Sural. So this much you have to explore in the roof of the posterior. And when we remove all these structures, so here this short saphenous vein, it dips into the D fascia, it pierces the D fascia and it opens into the popliteal vein, which lies deep to the D fascia. So when we remove all the structure of the superior fascia of the popliteal fossa, what we encounter? That is the D fascia. In the upper part, this D fascia is the fascia lata, which is attached to the lateral and medial condyle of the femur. And lower part, the D fascia of the leg is there. And the D fascia of the leg is called fascia cruris. So fascia cruris is in the lower part. So this is how we see all the structures here. So D fascia is everywhere, lying over here in the popliteal fascia. So everywhere after removing the superior fascia is the D fascia. And we cut it also in the same manner that is in the midline, and we refract the D fascia like the skin flap. Which is forming the roof of the popliteal fossa. So after the removal of the D fascia, we have removed the roof of the popliteal fossa. And after the removal of the D fascia, now we switch on to the next, the boundaries. So boundaries of the popliteal fossa, they are muscular. They are muscular boundaries, they are formed by the various muscles. As it is a diamond shaped fossa, so muscles which are forming the boundaries, they are superolateral, superomedial, inferomedial, and inferolateral. The superomedial boundary is formed by a muscle which takes origin from the upper part of the medial condyle, and this muscle comes downward obliquely and medially over the fibrous capsule of the knee joint, and it is fused with the soleus muscle, which is taking origin from the soleal line or spiral line on the tibial. So this muscle gets fused with the soleus muscle. This muscle is called the medial gastrocnemius. This muscle is called the medial gastrocnemius. Similarly, a muscle taken from the superior surface of the lateral condyle of the femur, it also runs obliquely downward and medially, like the medial gastrocnemius, and this muscle is also fused with the soleus muscle, which takes origin from the spiral line plus from the head of the fibula also, and a tendinous arc between the tibia and the fibula is the origin of soleus muscle. So lateral gastrocnemius and medial gastrocnemius is fused with the soleus muscle. Sometimes in 10% of the population, another muscle is also takes origin from the lateral condyle, runs over the lateral gastrocnemius, is the plantaris. It is also fused with the soleal muscle. This muscle is the plantaris. It is absent in the 10% of the population. So they are forming the gastrocnemiae, lateral gastrocnemius and plantaris. It form the infero-lateral boundary of the popliteal fossa. While the medial head of the gastrocnemius, it forms the infero-medial boundary of the popliteal fossa. Where they cross, they form the lower apex of the popliteal fossa. The superior-medial boundary is formed by the semimembranosus muscle. And the semimembranosus muscle is a ribbon-shaped muscle we have done in the hamstring. It comes vertically downward and inserted over the posterior surface of the medial condyle of the tibia. So this muscle, semimembranosus, it forms coming from medial side and forming the boundary. Then superior lateral boundary, and with the semimembranosus muscle, another muscle is coming also descending downward and going to insert on the upper medial surface of the shaft of the tibia along with the sartorius and gracilis. The semitendinosus muscle also there. So both semitendinosus and semimembranosus muscle, they form the superior medial boundary of the popliteal fossa. Then superior lateral boundary is formed by the hamstring muscle. We know the hamstring muscle on the lateral aspect is formed by the biceps femoris with short and long, both the heads. They unite to form a tendon of the bicep which is inserted over the head of the fibula around the fibular collateral ligament. So this is the biceps femoris muscle. So this is how a roughly diamond-shaped fossa is created, which is called the popliteal fossa, with all its muscular boundaries. Now the next part we have to cover is the contents. Contents of this fossa, they are the from deeper to the superficial relation. The deepest content is the popliteal artery. As we know, the popliteal artery is the continuation of the femoral artery in the hiatus magnus in the front of thigh. We have done that femoral artery, after passing through the hiatus magnus, disappears from the front of thigh. Now it will appear in the popliteal fossa as a popliteal artery. So here we see this is the hiatus magnus. So in this hiatus magnus, the popliteal artery comes now, runs obliquely, vertically downward, touching the popliteal surface of the femur, and descending downwards over the fibrous capsule of the knee joint and ligaments. After that, this popliteal artery then runs towards the upper part of the interosseous membrane. And here in the upper part of the interosseous membrane, this artery divides into two branches. One is running on the posterior surface of the interosseous membrane in the leg as the posterior tibial artery, and one artery goes in front of the interosseous membrane's upper border as the anterior tibial artery. Sometime a branch from the posterior tibial artery goes to the lateral compartment also. This is the popliteal artery. So this is how the obliquely running popliteal artery is there. And we know wherever the artery goes, veins comes from that area. The veins accompanying the all arteries, that is the anterior tibial artery, peroneal arteries and the posterior tibial artery, they accompany the veins, arteries, and all these vena comitants, they all unite to form what is called the popliteal vein. And this popliteal vein runs upwards towards the popliteal fossa, and the vein runs over the popliteal artery. This vein is now called popliteal vein. And this popliteal vein runs over the popliteal artery, and it is also marching towards the hiatus magnus. So it passes through the hiatus magnus. This is the popliteal artery. And then this popliteal vein, when it reaches through the hiatus magnus in the front of the thigh, now it is called, in the front of thigh, the femoral vein. But this is it. So artery lies deep, then posterior to the artery lies the popliteal vein. Then from the posterior dissection of the thigh, we already know that from the upper apex of the popliteal fossa, the sciatic nerve bifurcates into a medial and a lateral nerve. The medial nerve is tibial nerve and a lateral nerve is called common peroneal nerve. So here in the popliteal fossa, in the upper apex, we will see the bifurcation of the sciatic nerve. The tibial nerve runs downward and it passes over the popliteal vessels towards the upper part of the interosseous membrane. Here this tibial nerve is accompanied by the posterior tibial artery, runs on the posterior surface of the interosseous membrane. While the common peroneal nerve runs along with the tendon of the bicep, femoris, and at the head of the fibula. The common peroneal nerve goes laterally, and here it touches the lateral surface of the neck of the fibula, where it bifurcates into superficial and the deep peroneal nerve. The superficial peroneal nerve runs in the lateral compartment of the leg, while the superficial peroneal nerve is in the lateral compartment. The deep peroneal goes into the anterior compartment of the leg. So this is the picture of the contents of the popliteal fossa. The artery is deep, number 1. Number 2, popliteal vein, and number 3 is the tibial nerve. In the middle of the popliteal fossa, this tibial nerve gives a articular branch which pierces the deep fascia, the fibrous capsule of the knee joint, and this nerve supplies the knee joint. While in the middle of it also gives the tibial nerve gives a branch which is called the sural nerve. And this is the sural nerve which will pierce the deep fascia of the roof of the popliteal fossa, and it will run in the middle of the leg. So sural nerve is also given in the popliteal fossa. Along with this, then all the branches of the popliteal artery, they are also visible. Popliteal artery also gives the middle branch in the middle of the fibrous capsule, and this artery will supply the internal structures and synovial membrane of the knee joint. In the upper part, the popliteal artery will give a branch which runs laterally, supply the muscles there, and skirts around the lateral border of the bicep femoris, and then it goes anteriorly to the lateral condyle of the femur. Similarly, an arterial branch runs on the medial aspect and skirts around the medial condyle of the femur, and it also goes to the anterior or the front of the thigh. These arteries, they are called the Genicular Branches. On the medial side is called the superior medial genicular artery. Similarly, this artery is called the superior lateral genicular artery. Similarly, in the lower part, a arterial branch of the popliteal artery is given at the level of the lateral condyle, lower part of the lateral condyle. It supplies the muscles in the way, and this artery is also skirts around the lateral condyle of the femur and goes anterior front of the thigh. Similarly, a artery on the medial aspect of the medial condyle will also skirts around the medial condyle of the lower part of the medial condyle of the femur, and it goes anteriorly for anastomosis. And this branch which goes in the middle of the popliteal fossa is called the middle genicular artery. This is called the middle genicular artery. So this one is called the inferior lateral genicular artery, and this is called the inferior medial genicular artery. So these genicular arteries, they form a good arterial anastomosis posteriorly, and all these arteries, they skirts around the lateral condyle of the femur, and then all these arteries, they come on the front part and they supply the knee joints as the upper end of the tibia and the lower end of the femur. They is having very good arterial anastomosis, because we know knee joint is a weight bearing joint. Whenever we stand, whole of the weight is falling on our knee joint, so a good arterial supply is there. Accompanied by the arteries, we know all the veins, they are coming and they are opening into popliteal vein. So this is how the popliteal vein is having the venous collection. So wherever the artery goes, the veins, they come. So this is the arterial anastomosis around the knee joint. And all these arteries, they also form the prepatellar arterial anastomosis. Here, the genicular branch of the descending genicular artery and the descending branch of the lateral circumflex femoral artery reinforces these arteries, and the good arterial anastomosis is also present on the anterior aspect of the knee joint. So whenever a question comes of the arterial anastomosis joint level, the arterial anastomosis around the knee joint, so you have to make two diagrams. One is the posterior aspect, other is the anterior aspect. The prepatellar arterial anastomosis and the posterior anastomosis. So this is all about the contents of the popliteal fossa. Now comes what are the floor of the popliteal fossa. If we see the floor of the popliteal fossa from above downward, number one, floor is formed by the popliteal surface of the femur. In the floor, it is formed, number one, from above downward, popliteal surface of the femur. After popliteal surface, now the second is formed by the fibrous capsule of the knee joint. Fibrous capsule of the knee joint. Below the fibrous capsule of the knee joint, the floor is formed by the popliteal fascia. And this is the popliteal fascia, is nothing but this is the fascia covering the posterior surface of the popliteus muscle. Posterior surface of the popliteus muscle, which is inserted over the soleal line. So this popliteus muscle is very deep in position, and it comes to the rent of the fibrous capsule just behind the lateral condyle of the, we have already done. So this is the popliteus muscle. So popliteal surface of the femur, fibrous capsule, and popliteal fascia covering over the popliteal muscle, so they form the floor of the popliteal fossa. After removal of all these contents, we see the floor. Now the last comes the applied anatomy of the knee joint, of the popliteal fossa. So popliteal fossa is clinically important because of so many things over here. Number one, applied anatomy is related to the sural nerve. As you know, sural nerve is lying in the middle of the popliteal fossa here in the roof. So this sural nerve is a cutaneous nerve, and this nerve is very much used for nerve grafting. So wherever there is any accidental loss of the nerve is there, so that portion of the nerve can be replaced by the sural nerve, because there is a good sensory communication of the nerves are already there. Second applied will not be related with the, and sural nerve can be easily identifiable also, because it is accompanied by the short saphenous vein, which is a superficial vein, and it is bluish in color. And we know their mutual relationship. So sural nerve lies very near and parallel to the short saphenous vein. So during surgery, we can easily identify this nerve running parallel to the short saphenous vein. Second applied anatomy is that the popliteal fossa is also used for measurement of the pulse. If some patient is coming to you whose both the upper limbs has been amputated, so you can't find the radial vein, then you just semi-flex the popliteal fossa and put your fingers behind. You can see the pulsation of the popliteal artery. If you gently press this popliteal artery against the popliteal surface of the femur, same as we are pressing the radial artery against the lower end of the radius, the bone. So here also, as popliteal surface is giving no muscle attachment, so we can easily press it against the popliteal surface and pulsation can be held and counted. Number 3 is the blood pressure measurement. So if the upper limbs they are amputated, then we can apply the cuff of the blood pressure over the lower part of the thigh, and we can put the chest piece of the stethoscope on the popliteal fossa, medially in the upper apex, and we can measure the blood pressure also from the popliteal fossa. Then fourth clinical value is the, we have already discussed, is the cutting of the common peroneal nerve along with the semitendinosus muscle in the case of the spastic paraplegia. Spastic paraplegia, so you can repeat this in this separate also. Then the popliteal fossa is also very useful in case of the fracture of the lower end of the femur. Fracture lower end of the femur. If a patient comes with the fracture of the lower end of the femur, a orthopedician should know what is the relationship of the popliteal artery with the popliteal surface of the femur. So if there is a fracture over the lower end of the femur across the popliteal surface, as we know, the popliteal artery is touching the popliteal surface, and if the fracture line goes here, including the popliteal surface, then popliteal artery is liable to be ruptured, or it is tear may be there because of the two fragments of the fracture line. And because of the rupture of the popliteal artery, what will happen? Distribution of the blood to the leg and foot will be stopped. It will be stopped. So whenever a case of the fracture of the lower end of the femur will come, because of the anatomy of the popliteal artery with the popliteal surface or the lower end of the femur, surgeon should always check the pulsations in the dorsalis pedis artery. If a surgeon doesn't see the dorsalis pedis artery and popliteal artery has been ruptured in the fracture, by mistake the surgeon has not checked the pulsation of the dorsalis pedis artery in this accidental case and sent the patient to the ward or in the room, then because of the stoppage of the blood supply to the leg and foot, patient will suffer from the gangrene of the leg and foot. Because of the avascular necrosis of the muscles of the leg and foot. And patient has to suffer from amputation of the leg and foot. So because of the negligence of the surgeon at the time of the admission of the patient of the lower end of the femur, patient has to lose the leg and foot for whole of the life. So this should be the mistake not to be done by a surgeon. Then all the problems of the joint, the arthritis. So arthritis is the condition in which there is an inflammation of any of the structures of the knee joint. So here the popliteal artery, popliteal fossa is involved because the lower end of the femoral and upper end of the tibia. The bones may be involved in the gouty arthritis or infective arthritis, non-infective arthritis, osteoarthritis. So any affection of the knee joint will lead to the painful pain in the popliteal fossa. Then any rupture of the artery and the popliteal vein will lead to the collection of the bleeding will be there inside, and that blood is called the hematoma. So after the injury of the popliteal fossa, the hollowness of the popliteal fossa will be obliterated because of the collection of the blood into the popliteal fossa. So fossa is no longer fossa, there is no depression, and it is also the sign of the rupture. Then popliteal cyst. So popliteal cyst is the swelling over the, usually in the middle of the popliteal fossa. This is called the popliteal cyst. It is due to the leakage of the synovial fluid from the fibrous capsule of the knee joint posteriorly from a small hole or the rent in the fibrous capsule. So that is the cyst, and this increase in the size of the cyst may prevent the full flexion of the knee joint. Knee joint is not fully flexed, so that is the problem. So these are the applied anatomies which is related to the popliteal fossa we have to understand. That's all.